Top Bed Talk.
So our next speaker is Enoch Akowuah. He's going to talk about cardiac prehabilitation trial. He's a professor and chair of cardiac surgery at Newcastle University and a consultant cardiac surgeon at South Tees. It's early breaking news that his data that he's publishing today has just been published in anaesthesia, so we're very honoured and excited to hear your talk. Thank you.
Thank you very much to the organisers for giving us the opportunity to present our data, that Sandy says, for the first time anywhere. So we have a long track record of trying to get evidence for our practice in cardiac surgery, and for some things we've got really strong evidence. So, for example, TAVI in the elderly or revascularization in patients who are diabetic, the evidence for that is really, really strong. But over the years, we've sort of got bitten by a number of things which we thought were brilliant, but then eventually when we got the evidence for discovered maybe not to be not as good as we thought. So off-pump surgery is a good example of that, which for 20 years we thought was the best thing ever. And then when we did the big trials, we discovered that actually the benefits were quite limited and in quite selected groups of patients. So for us, we really need to urgently work out whether Prehab is evidence-based or is hype-based. And that's really where the PREP trial starts. So it was really interesting yesterday hearing about the evidence in the cancer sphere, because clearly you've got that and you've moved on to implementation and delivery. But the evidence base for Prehab in cardiac surgery is extremely poor. And as a consequence, there are very few Prehab programs anywhere in the world, really. In the UK, we did a survey a number of months ago, and of the 37 cardiac surgery units, only 4 offer any form of Prehab. And in those 4 units, Prehab is pretty light touch, and they're called Prehab, but I think most of you, when you see what they do, would probably disagree that it's real Prehab, if you like. And the reasons why we don't do it are centered around these 3 concerns, really. So questions around efficacy, questions around feasibility, can we fit this complex intervention into our pathway, and then questions around safety. And the PREPS trial was really designed to sort of shed light on all 3 questions. So it's an interventional randomized controlled trial looking at elective patients having cardiac surgery, and we included all adult patients. The sample size was 180 patients, and they were all followed up for 12 weeks after surgery. So the control arm got standard care, which is just standard pre-assessment visits and the routine appointments you'd have with the specialist nurse, and advice and consent relating to the upcoming surgery. And the intervention consisted of these 4 aspects, really. So there was an initial fitness assessment, and then patients had 2 supervised sessions a week, planned over a period of 4 weeks, each lasting an hour in our exercise gym at South Tees. They were then prescribed home exercise, which lasted 45 minutes, and they had to do that every day. And then they also did high-intensity inspiratory muscle training twice a day, every day, for the duration of the intervention. All participants kept a diary, so we knew what they were doing at home, both for exercise and for IMT. And we followed them up prior to surgery, obviously while they were in hospital having their operation, and then 6 and 12 weeks after the next operation. So the primary outcome was a change in functional exercise capacity, which we measured using the 6-minute walk test distance. The secondary outcomes included a change in inspiratory muscle strength, anxiety and depression, and quality of life. And then we had some safety outcomes which are predefined, and these were death and adverse events. We also had 2 sub-studies, one being a nested qualitative sub-study to look at the experiences of the patients and the staff who were delivering the intervention, and then an accelerometer sub-study where patients wore accelerometers so that we could really quantify physical activity at home. I won't be presenting any of those results today. So what did we find? The first thing is that we had to screen an awful lot of patients to get 180 patients. So we screened over 1,000 patients. Over half the patients we screened declined participation in the trial. And the commonest reason for that was because they didn't want to travel to the site for the intervention. The second big group of patients were those who were ineligible. And the commonest reason for that was because they were having a complex operation or had a complex history, which meant that we could not fit the Prehab intervention into the pathway. But we did recruit all 180 patients and over the COVID period. So a significant challenge, but one that we delivered. So those 180 patients were randomized into the 2 groups. 91 patients had intervention, 89 patients had control. And importantly, over 90% of patients were followed up to the end of the study. So we managed to keep the patients in the trial. Baseline characteristics of the two groups were fairly similar. The majority of patients were men, and I'm afraid this is one of the problems with cardiac surgery. Over 70% of patients who have cardiac surgery anywhere in the world are male. In the UK, it's about 75%. So I'm afraid it just sort of is a reflection of the praxis. A third of patients were over the age of 70. We didn't have many frail patients. Only over 90% of patients had a Rockwood frailty score of less than 3, and about 2/3 of the patients were having revasc as opposed to valve surgery. Compliance was overall pretty good. So 71% of patients fulfilled our pre-specified criteria for compliance to the in-hospital intervention. 80% of patients did the home exercise. Nearly 80% did the high-intensity inspiration muscle training as well. Patients who were older, over the age of 80, were more likely to adhere to the intervention than those who were younger. And compliance did not differ depending on whether you were having valve surgery or coronary surgery. The primary outcome was not significantly different between groups. So this was the change in 6-minute walk test distance from baseline to pre-surgery. And that was the case for the primary analysis, which is intention to treat, but also for a number of sensitivity analysis that we carried out. Importantly, even at 6 weeks and 12 weeks, there are still no significant differences between groups in terms of the 6-minute walk test distance. We found a significant interaction, however, with sarcopenia. And we found that 27% of patients at baseline were sarcopenic. We measured this using the hand grip strength. And we found that in patients who were sarcopenic, 6-minute walk test increased by 50 meters in the prehabilitation group, and the interaction was significant. In terms of the secondary outcomes, there was a significant impact on inspiration muscle strength in favor of prehabilitation, and that impact seemed to persist all the way to 12 weeks after surgery, although they stopped training prior to their surgery. We found no difference in anxiety or depression scores. And then finally, we found no difference in health-related quality of life when we measured it using EQ5D5L as well. So then safety. We found 71 adverse events in the whole cohort, and about 2/3 of that was in the Prehab arm. Interestingly, though, only 6 of these 45 events were deemed to be directly related to the Prehab intervention. And we saw something similar with the serious adverse events. There were 7 SAEs reported during the trial. 5 of them were in the Prehab arm, but only 1 was deemed directly related to the Prehab intervention. On this slide, I've listed the directly related events. And of note, the first one, which is the SAE, was a patient who became unstable during prehabilitation training and was admitted and had urgent surgery for unstable angina. There were 4 deaths in total in the cohort, 2 in each group, and in each group 1 patient died before surgery and then 1 patient died after surgery, so no meaningful differences. And then finally, we looked at a number of clinical outcomes. There were no differences in length of stay overall, no differences in the length of intensive care stay. We had a composite of surgical complications, which were similar, and similarly, there were no differences in primary pulmonary complications between groups. So to conclude, in terms of the 3 objectives that I set out at the beginning of the talk, there was no difference in the primary outcome of change in 6-minute walk test distance between groups, although sarcopenic patients may benefit. There was a significant improvement in the MIP, but of course, this was a secondary outcome. There was an increase in the number of patients who had adverse events in the Prehab arm, but we suspect this might be due to reporting bias, but clearly we need more data to confirm safety of prehabilitation in this cohort of patients. And then finally, when it comes to feasibility, for those who took part in the program, compliance was high both at home and in hospital, but travel was clearly a barrier to participation. So we think that future trials should probably be targeted to the patients with sarcopenia. We need to explore the impact of IMT training more in this group. We saw a 20% reduction in PPCs, but of course, this wasn't powered to find a significant difference, but that's an interesting outcome to explore further. but we clearly also need some information about safety in prehab and cardiac surgery patients. I'm delighted to say that both the main trials, the data that I've presented here, and the qualitative sub-study are both published today. So please look at them, because there's lots more information and data about what we did in those papers. And I'd like to say thank you to the editors of Anesthesia who worked really hard with us to get them published for today. And obviously to say thank you to the patients and my wonderful prehab staff, some of whom are here, and everyone else who helped us to get this up the line. And finally to the sponsor as well. Thank you very much.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.